Thank you very much, Francis. And those of you who are in the last session will know that my job wasn't made easier by the interaction. The expectations were set high. Look, I'd have to be honest and say I'm a little nervous talking today because last year, for those of you who were there, I was speaking about one of my favourite subjects, or dealing with challenging and difficult behaviour, which is actually, the topic today is a little bit drier than that, so I'm sure I won't get 5 stars from all delegates for this topic. But nevertheless, it's something I feel very passionate about. It's a field I've been working in now for nearly 13 years, and I'd like to share with you some of my thoughts and ideas around open disclosure and what I think are the benefits for us as professionals in healthcare from an effective open disclosure implementation, and also the benefits for our patients. And I call my talk Meeting the Standard because I'm very conscious of the fact that, as you know, with the accreditation standards, there is a new standard for open disclosure, and I'm going to talk about the technical aspects of that requirement and give you our take on how you may meet that requirement for accreditation. But before I do that, I wanted to talk about, perhaps more importantly, what is the standard that we want for open disclosure in our organisation, not the one that's actually mandated by the accreditation authorities. And I think, you know, in healthcare it's complex to deliver good care. We've heard speakers in this conference talk about reliability and excellence, and we certainly support the push for reliability and excellence in healthcare, but it's very hard in the complexity of the technical aspects of what we do to actually achieve that at all times. However, in the area of open disclosure, I would make the case that this is an area where we can achieve highly reliable excellence at all times, because it's essentially the question that I would pose to you is the standard of open disclosure required should be one that we would expect for a family member in our institution where something had gone wrong. If you imagine one of your children, your spouse, one of your parents being admitted to your institution and things not going as well as hoped, what's the standard you would expect in terms of the discussion, the support, both for the patients and the clinicians involved? That's the standard I would argue we need to be implementing. And to the extent that the accreditation process supports that, I think that's a great thing. But I would make the case, and I hopefully will make the case for you today, to go well beyond just what's required by the accreditation standard, to think about what would I expect in my institution if one of my relatives had the misfortune of suffering an adverse outcome. What's the level of communication support that I would expect? Some of you would know the story of Cognitive Institute. We're a Brisbane-based organisation, and we do communication skills training across the Asia Pacific, and we also, through our parent organisation now, which is a non-profit trust in the United Kingdom, the Medical Protection Society, provide our courses to clinicians in the United Kingdom, South Africa and the Republic of Ireland. And each year we have about 30,000 clinicians do our courses across the world, supported by our fantastic team here in the Brisbane office. We have doctors and other clinicians who work for us delivering the messages around open disclosure, around communication skills, risk management, leadership and reliability. Particularly in the area of open disclosure, as I mentioned, we've been doing this work now for 13 years, and we've had over 11,000 clinicians undertake our more detailed open disclosure training. And we've been involved in supporting hospitals across the Asia Pacific, in Australia and New Zealand and Singapore in particular, either directly or through in-house licensing to deliver extensive open disclosure implementation policies, procedures and training in their organisations. In particular, as I'll talk a little bit later on in my talk, we have a program called the Clinical Incident Management Program, which is designed to support clinicians and patients and institutions through the most traumatic adverse outcomes to ensure that open disclosure is done well. So, as I said, today I'm going to talk a little bit about the technical side of what's required to help you meet the new accreditation standards, and then talk a little bit more about how we think you can use open disclosure to drive excellence in your organisation. The Open Disclosure Framework was released in 2013. Previously, there was the Open Disclosure Standard, which was, I think, finalised in 2003. And the framework was a review of that standard. And this is the definition that is within the framework. And I have no problems with that. I think that's pretty much world best practice. What we've known for a long time is that if you ask patients what do they expect when things don't go the way they expected, it's pretty clear what they want. They want the truth. And in fact, as we're seeing played out, whether it be in hospital inquiries or in this country, the Royal Commission into Institutional Abuse of Children, we're seeing any perception that an organisation or the individuals within the organisation are not being truthful and open and honest is met with less than favourable response. And I think it's in our best interest to be truthful and open with patients, and certainly that we know that the research strongly supports that desire. Patients need to have their story heard and acknowledged. It's not enough just to say yes, 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 yes. You actually have to take it on board and incorporate it both into the experience of the organisation, but also the way in which you respond. They require information to their level of satisfaction, not information to the level of the hospital or institution satisfaction. An expression of regret or sorrow, information on how similar outcomes will be prevented in the future if possible, and an agreed plan for ongoing care. And just to put to bed any of the sort of ideas that patients really don't want to know the truth and maybe it's best just to leave it alone. I put some early studies there, but there is just study after study showing that patients want to know the truth. That sort of paternalistic approach of let's not bother them really has no place in the 21st century. Why are these principles being advocated? Well, obviously, primarily it should be about our ethics. The ethical duty to act in our patients' best interests, and that includes patients' best interests psychologically, not just physically. But it's more than that. We also know that transparency and openness is a powerful driver for excellence. And we know that a blame and shame culture, which actually often hides the true cause of why things have gone wrong, can actually interfere with patient recovery and indeed interfere with professionals exercising their ethical duty. And also there's now overwhelming evidence from particularly the Northern Hemisphere, but I'll show you some evidence from our work in the Southern Hemisphere, showing that when we do this well, it helps patients move on. It actually helps their acceptance. And I like, in my teaching around open disclosure, I remind my colleagues that every patient going through a serious adverse outcome is going through a grief reaction. And the fact that we cause the grief reaction doesn't mean that we still shouldn't be the experts at dealing with that grief. And patients expect that when they suffer a grief, an incident causes grief, that we should be there to help them. It's no different when we may have actually contributed to that causation of that grief. It's very interesting, as I said, I'm getting old and grey, and when I first started in this field 13 years ago, there was a very strong push, I'd have to say primarily from North America, driving open disclosure as a way of reducing the risk of litigation and complaint. It was basically, look, we've just discovered, surprise, surprise, that if we're open and honest, patients may not sue us so much. And this flowed out of research studies done in the 90s that showed one of the primary motivations for patients initiating a claim or complaint was a desire to actually have a full account of what actually happened. They were just stonewalled, and they finally had to go to a lawyer to try and get the answer. It wasn't the only reason, but it was a major reason. And when that major reason was actually taken out of the equation, well, the risk of complaint and claim dropped. And this drove a frenzy of activity of, this is the answer for the litigation explosion. So going back to your need for meeting the accreditation standard around open disclosure, as I said, the standard was published in 2003. It was revised in 2012 as a report and then released as a framework in 2003. And there were some significant findings in the review. It was very clear that patients wanted to have more dialogue than was originally proposed in the standard, that clinicians, despite the protections for expressions of regret that were enacted in all states and territories as part of the tort law reform in about 2002, 2003, clinicians were still concerned about having conversations with patients. There was a lot of misinformation that being open and honest with patients could still increase your risk of complaint or claim. And highlighting what I perceived across the world, I think disclosure, there's been a greater push for disclosure as an ethical practice rather than a risk management or claims avoidance practice. So as a result of the framework being released, this has now been incorporated into the NSQHS standards that are used for accreditation for hospitals in Australia. And I just want to show you the relevant pieces of that standard. The standard's objectives are to protect the public and improve the quality of care of the health service, quality assurance and quality improvement mechanisms, standards integral to accreditation, and using accreditation as a driver for safety and quality improvement. Standard 1 is around the governance for safety and quality in health service organisations, and this is the general standard under which open disclosure is referred to. And particularly it comes down to sections 1.14, 1.15 and 1.16, which relate to incidents and complaints management. And particularly, as you can see in 1.16, the criteria 1.16, there is a requirement for accreditation to implement an open disclosure process based on the National Open Disclosure Standard. Now, immediately you'll identify that there is no open disclosure standard. It's now called the framework. So the standard 1 is around governance, and criteria 1.16 requires implementing an open disclosure process based on the National Open Disclosure Framework. In giving guidance around that, you will see that there are two elements or two actions required. An open disclosure program is in place and is consistent with the National Open Disclosure Standard / framework. But of most interest is 1.16.2, which is a requirement that clinical workforce are actually trained in open disclosure processes. And for your reference and essentially to establish Australia's leadership in this area, this is, to our understanding, is the first country that has mandated open disclosure training. Despite the fact that there's been a huge amount of media in the UK around the Being Open statement that was put out in 2005, despite the fact that many leading healthcare organisations in the US have extensive experience of open disclosure implementation, we are the first country to mandate training of all clinicians, and I think that is very significant. What's required to meet the standard? Well, it's a bit difficult to sort of pick it out. In conversation with Minter Ellison and in consultation with the appropriate bodies mentioned already, the current evidence suggests that all clinicians need some sort of general introductory and refresher training. Particular to the standard is the requirement for specialised coaching of a group of experts who support others following an adverse outcome and during open disclosure. The idea of having an expert on site or having expertise available, a senior clinician specifically trained in open disclosure, is an attempt really to ensure that the response to a serious adverse outcome is not time and date dependent. It's not that, yes, we actually respond really well on Tuesday afternoons, but we're actually really poor on Saturday mornings. It's really a way of trying to build into a system rather than an ad hoc, let's hope that Mary's on because she's really good at dealing with unhappy patients. Moving to rather, how do we ensure that we have a group of people who are able to provide that support to patients, our families, and indeed our clinicians at any time of the day. And there's also a particular requirement which is just-in-time training immediately available before undertaking a conversation with a patient or family. So in other words, the ability for a clinician who's about to undertake a conversation to just be reminded of the key principles. Oops, all right. A lot of the phone calls and queries that we've had have come from very small institutions, day surgeries, endoscopy units, saying, well, how does this apply to us? And if you look in the standards, there's a specific reference to small hospitals or small facilities, but in fact the requirements are no different. So even though they're specifically mentioned, the actual requirements are actually no different than if they were a large teaching hospital. So what do you need to look at from your point of view as an organisation for compliance? Well, at some point you're going to need to allocate some resources to support open disclosure, because you are going to be required to undertake the training and to provide the policies and procedures. You will need to have some access to just-in-time training, and you probably will need to think about how you're going to disseminate that information to your staff. There's also a requirement that patients are informed about your open disclosure policies and procedures and your complaint processes, that you've been able to identify staff who are capable of undertaking that expert role and that they've been appropriately trained. The importance of an after-hours response, that it's just not a Monday 9 to 5 response, having systems to identify adverse outcomes, and of course mentoring and review. The standard also gives advice as to the requirements for open disclosure training, and of course we've incorporated those into the training that we offer. They're available obviously if you're going to source your training through other providers. So that's the technical side of it. That's the standard, the framework, and what we believe is the current requirement for this accreditation cycle. But I'd like to spend a little bit of time talking to you about what we believe is the value of actually doing this beyond just compliance. We've had the privilege of working with many organisations who've gone well beyond baseline compliance. For example, in Singapore, we've had a whole of government implementation process with virtually every public hospital and many private hospitals undertaking extensive training of their clinicians in open disclosure processes. I mentioned the Mater hospitals here in Brisbane. In 2004, we commenced working with them, training, I think initially 8, but we now have 14 or 15 senior clinicians who have undergone a 2-day training program, which is designed to both support patients, the institution, and their colleagues undertake the most difficult adverse outcome conversations after serious consequences for patients. And rather than this being a cost to the organisation, one that's added to the burden, it's actually done, the impact has been the opposite of that. It has been cost effective, in fact more than cost effective. It has contributed to significant culture change in those organisations. It has contributed to an environment of transparency and openness that has driven quality improvement and excellence. And it has also sent very important messages to the staff of those institutions around the organisation's awareness of the impact of a serious adverse outcome. So we believe there are many benefits from an effective open disclosure program, not just safety and quality and organisational learning, but enhancing clinicians' competence in handling grief, which they can actually take over into other grief reactions that their patients may experience. A reduction in patient complaints, and for those of you who have any interest in the financial returns, they're pretty impressive, so I'll show you some of that data. Reduced risk of medical claims, but also increased patient satisfaction, trust from your clinicians and staff, an improved organisational culture of openness, and as we've seen again in all of the inquiries, the Royal Commissions, whether they be healthcare or otherwise, reputational protection when we respond to things not going well in a professional and open way. As you can tell, I believe that open disclosure can be more, implementing an open disclosure program can be more than just trying to meet the accreditation standard. I think it has the potential to assist you drive a culture of excellence, transparency and openness in your organisation. We understand that there are significant issues in the private sector, and in fact we've assisted a number of private hospitals in Australia over the last 12 or 13 years to implement their open disclosure programs, and we understand the whole issue of VMOs not being employees, the resistance that may be involved. There may be a lot of myths out there that if you're open that you're going to increase your risk of litigation or complaint, which in fact the research is very clearly saying the opposite. and that it will adversely affect patients, that, patients can't handle the truth. We understand that, you're running on tight margins at times, and this can look like another requirement. You can also be wondering, well, who are going to be our experts? Who can we actually identify amongst our executive team or amongst our VMOs or amongst our nursing leaders? Or you may be concerned that you're just too small and that you don't have the resources to do this. Let me tell you that there are ways around these barriers, and we can give you advice if you need them, if you need that advice as to how these can be addressed. So what should your organisation do? Well, this is from the Australian Open Disclosure Framework, and I won't read it out to you. It's pretty straightforward, and you can access that through their website. One of the commonest questions we get asked was, well, how do you juggle this stuff? I mean, we have things going on in our hospital all day. Do we have to send an expert out every time we don't put a Band-Aid on properly? And the framework has tried to differentiate between low-level responses and higher-level responses. And effectively what's being, the case is being put that for lower-level responses, this is something that clinicians, local people in the unit should be able to handle because they've been trained in open disclosure, so that you can leave it to the doctors, the nurses, the staff on the unit in your wards to actually handle these lower-level things because they have been trained in open disclosure methodology. But once you start getting to more serious incidents, then the advice is that you should look at having some local expertise, that one or more people in your organisation have actually undertaken more extensive training in open disclosure and understand the principles of how to not only ensure the organisation is well represented, but that patients are well looked after and that clinicians' concerns are heard as well. So in our CIM program, for these very serious incidents, we suggest that there should be a team involved, a team coordinating care. And I'm aware that many of you already have something like this. And the people on that team can include some or all of these people, or in fact even others that you may have in your organisation. But as a minimum should include the treating doctor or nurse, someone who's able to represent the hospital's risk management / complaints process. If there's the issue of indemnity or likely to be a legal claim, some sort of person in the organisation who's able to represent that. And on whatever team you put together, we would suggest a CIM senior consultant. This is a senior clinician in the organisation, either a practicing clinician or someone, a clinician who is on the executive, who has been specifically trained to support open disclosure and to ensure that it's done well. And their job is really to ensure that these 4 pillars of an effective response are handled. The psychological needs of the parties, the clinicians, the patient, the safety and quality agenda for the organisation, the whole issue of compensation restitution if it's felt that there's likely to be some financial consequences, and any legal and regulatory requirements that are associated with the incident. And essentially the training the expert training is essentially training senior clinicians in how to ensure that these 4 areas are adequately addressed for the benefit of the patients, the organisation and the clinicians. So we say that the role of the expert is to ensure the psychological needs are met, to ensure safety and quality issues are communicated with the patient and that patient's concerns are addressed, to represent the hospital and the clinician's agreed response to the patient, because as you know, many adverse outcomes, one of the signs of a very poorly managed adverse outcome is the patient getting 3 stories. And I can tell you many times, and I'm sure you've got your own horror stories, of a series of people coming in to talk to a patient and family and saying, I'd like to be open and honest with you, here's what's happened. Patient and family take that on board. An hour later, someone else comes in and says, I'd like to tell you what's happened openly and honestly, and tells actually a different story. And then 4 hours later, someone else comes in and says, we want to be open and honest with you, here's what happened. And I'm aware of one case where there were 6 different people in a period of 24 hours came in and gave the patient what happened, and most of those versions were contradictory. That did not inspire confidence. So I think there's that whole element of coordination around what do we know and what do we communicate to patients that is factual, that is free of opinion, and can be represented as being truthful no matter what your perspective. Obviously, we think there are a lot of advantages of the CIM model, but the one that, as a clinician myself, that I would advocate for is support for clinicians. I know that there's many former clinicians in the room. Many of you will remember your first adverse outcome. You'll remember the feelings that you had. You'll remember the horror the first time you recognised that you may have actually made someone worse. And that was never your intention. And I believe that by doing open disclosure well, we can actually change, within a generation, the culture of clinicians as to what is a healthy way to respond to the fact that we can do harm. Rather than maladaptive defence mechanisms that alienate patients, actually impair improvements in quality and safety, and damage clinicians, we can actually do it a lot better. And so for that reason alone, I think it's worth looking at. We've actually seen in organisations that have done open disclosure well cultural change, not just around how we respond to adverse outcomes, but as I said, around transparency and openness. And I think that when you do this work, you will be surprised. I think the feedback that we get is that clinicians, while some are initially resistant to the idea, are actually relieved that when they actually hear about the principles of open disclosure and how it's designed to be supportive of clinicians as well as patients, are actually relieved, and it's been well accepted and well appreciated, not just by organisations but by the clinicians themselves. It's also been a great source of relief, I think, to patients and patient advocacy groups that there is a movement within healthcare to address what has been an open sore for decades, the challenge that patients and families have getting accurate, quick information about what's gone wrong when they or one of their loved ones has been damaged by healthcare provision. So thank you very much for listening to me today. I'm very conscious that part of this was a pretty dry talk around accreditation and requirements, but can I again encourage you to think of your attempts to meet the open disclosure standards for accreditation as being more than just a compliance measure, that you can actually link this to your efforts to drive excellence and reliability. And I think this is an area of particularly of highly reliable, excellent practice that is actually quite easy to achieve. And I'll leave you again with the challenge that I put to you right at the start of my presentation. If one of your relatives was admitted to your institution, how confident are you that if something went wrong, the response of your organisation and the clinicians would be ethical, just, open and transparent? If you think there's a gap there, then I think embracing the requirement for open disclosure in the accreditation standards is actually an opportunity to address that gap. So thank you very much to APHA for the invitation to speak, and thank you for listening to my ramblings again, and I wish you all the best for the rest of your conference. Thank you very much.